Tahir Verawala, Partneri.
Good evening, everyone. I'm Rotaractor Tahir Varawala. I would like to start off by extending a warm welcome to Dr. Yasir Zahid and his team who will be conducting the session for us today. Dr. Yasir Zahid is a certified manual therapist with degrees of BPT and MPT. He is also a member of the Indian Association of Physiotherapists. Dr. Yasir has tons of experience up his sleeve. Currently, he's a senior physiotherapist at H.E.A.L Institute. He was a professor at Dr. M.V. Shetty College of Physiotherapy, Mangalore. Also a former physiotherapist at Noor Hospital, Kurla, and at Care Hospital, Malad. He has also had his own clinical practice. It is a pleasure to have Dr. Yasir and his team amongst us today.
Hello, hi, good evening all. Am I audible?
Yes, Dr. Yasir, you're audible.
Okay. First of all, thank you all for giving me this opportunity, and so that we present our ideas on the selected topics that we have got. So I thank you firstly the Medicrew of the Rotaract Club.
Everyone welcome.
Am I audible? Yes. Okay. It's slightly echoing. Okay, also with me is Dr. Rajat, who will be the model for today, that when I demonstrate exercises, he will be along with us. Okay. So workout biomechanics with respect to injuries. Okay. Meaning that when we have our workout sessions and we have certain faulty biomechanics and we are prone to injuries, right? So what are those movements that cause different types of injuries? Okay, so keeping it, so we'll start, for example,
Pakistan Airlines की flight हुई, तो कराची मुंबई में पाकिस्तान जो ठहरा, कराची पाकिस्तान ही ठहरा, ये भी कपड़ा में क्या मत किया, सुनता है, पाकिस्तान में रेंडियर शूट हुआ,
lot of noise.
इंडिया पाकिस्तान में, पाकिस्तान ये कंट्री जो है बोला,
Can we remove this?
Can I have somebody who's watching? All right. Can I get feedback because I'm not getting an idea? Tahir, can you be on because I'm not getting an idea?
Yes, yes.
Okay. Right, great. Yeah, works. Okay, so we'll start with something very simple that when we exercise and we go wrong, okay, so faulty biomechanics can actually cause some injury, right? So we need to be, good when we choose our exercises, the correct range of motion, the correct intensity, your correct amount of load that we are giving to our patients or your clients. Okay, as simple as that. I'm going to start with something very basic example, such as a T-row. All right, so I'm going to use this TheraBand. Okay, I'm going to use this green TheraBand. And okay, so when we do these T-rows, as simple as, okay, T-rows. Okay, so a T-row can be done with a palms down and palms up. Okay, right? We'll demonstrate. Come forward, come forward. Okay, T-row, right. So here with me is Dr. Rajas. He's my colleague. Okay, so I'm allowing Dr. Rajas to do all possible, um, you know, things that he can do. So T-rows, yes. Oh, so would that be a correct form of exercise? No. I would want Dr. Rajas to hold it at shoulder width apart. Okay, at shoulder width apart. Okay. Yes, shoulder width apart. Okay. And then pull it across your chest, right to the sternum. Correct. Right here. Okay. Okay. And pull back. Okay. So that's a T-row. So the same thing, if I do it with palms up. Okay. And pull. So that is also a T-row. The difference between the two T-rows is one is a deltoid dominant. Okay, when you do a T-row, one is a deltoid dominant, and the other is a biceps loaded. You're loading your bicep, and it's a bicep dominant exercise. So that's just an example to start with, that how you can actually differ in doing the same exercise but differently. So you need to choose it wisely, that when and what exercise has to be chosen for a specific condition. Same thing goes with different exercises. So your load alters. So if your load alters, your movement is altering. Okay. Okay, so when you are doing your bicep curl or you are doing a chest press, okay, the amount of load that you take is going to alter your movement and the position of your joints. Okay, so specific muscles, okay, will have specific movements. Example, your rotator cuff. Okay, if you're doing rotator cuff exercises, okay, so when you do a standing outward rotation, that is your infraspinatus. Okay, so a specific movement is a specific exercise. All right, but does a specific movement isolate a muscle? Does a specific movement isolate a muscle? All right, no, exactly. We do not isolate muscles when doing a specific. One more example to this is that when usually we as physios or as physiotherapists, we say VMO, that we need to do your VMO, right? Strengthen VMO for osteoarthritis, strengthen VMO for your knee extension, lags, etc. Right? So vastus medialis obliquus per se cannot be isolated from your quadriceps. When you do your VMO, you are actually activating your entire length of the quadriceps muscle, right? So you pull your quadriceps, you do your VMO. So same thing, that when you do any shoulder exercise, okay, that be your inscription, raising your arm inscription, you're doing your delt fly, you're doing a shoulder press, okay, all of it, okay, you are activating your entire rotator cuff and not just isolating your infraspinatus or subscap. But yes, can we have exercises that can be dominant on others? Okay, okay, can we have exercises by a muscle which can be dominant over the other muscle? Okay, yes, yes. So let us say when you do a bicep curl, you are, yes, dominating your biceps brachii. When you're doing your hammer curls, you are doing your biceps and you are developing biceps. But at the same time, okay, you are using abdominate brachioradialis. So, and hence two different type of exercises. Okay, so a bicep curl, okay, when you choose to do that, you're developing more of your biceps. Okay, when you do a hammer curl, okay, you are focusing on more elongating the biceps tendon. Okay, it's more of, you know, eccentric. Yes, you do go, but when you come down, it's a lot of eccentric control that we see with that exercises. Okay, so as I was saying, the different movements and isolated muscles, two things there. Now, how do you progress? How do you progress for any exercise? Okay, you have load. You need to increase load. Okay, load the muscle. If you want to progress with any exercise, increase the load or load the muscle well. Okay, have a planning to that load. Proper movement execution, that ranks second. Okay, so you need to have proper movement, okay, proper positions for exercises. And third is the range. Okay, you need to have a good range to do that good exercise. But at the same time, is the range only thing to do your exercise? Do you need to have a full range of motion to actually develop that muscle? Okay, let us say anything. You can actually do exercises in half the range or 3/4 of the range of motion and still develop exercises. When you see you know, a professional bodybuilders who are really bulked up, they are compromised with their range of motion, but they still do well with their muscle tone or increased hypertrophy of the muscles, or they develop well. Okay, but they're compromised with range. So since so I'm keeping, when it comes to muscle loading and all of that, let us say training, I keep ranges to on the rank 3 or the third priority. First is load, that you need to load a muscle to actually develop. Okay, so this program of ours also includes that uh, that how tissue responses, or when we have injuries with those faulty biomechanics, which I will be demonstrating later. I'll take some time to come for it. But when we have that tissue, when we target tissue healing, when we have injury and when we target tissue healing, okay, there are phases to it. So so we have different stages to it. Okay, that is the inflammation stage, that is lasting for 3 days. We all know that, right? Then you have got the repair phase, that is for 3 days to 6 weeks, that can last up to. And we also have the remodeling phase, that is from 6 weeks to 12 months. So again, when you have let's start connecting that we have a faulty biomechanic, we have an injured tissue, we have had an injury. Now that injury has to be healed, coming back to its phases or what stages it comes down to, right? So you have got the inflammation stage for 3 days, okay, then 3 to 7 days, almost a week's time. And then we have got the repairing phase, okay, wherein the tissue repairs itself, proliferation happens, the collagen comes in, and then the fibers get knit well. Okay, and there is abrupt scarring of tissues inside, etc., etc. You do something, do not do something, tendons, ligaments, muscles will heal. It will heal by itself. So with exercises, what are we doing? We are promoting proper alignment of those collagen fibers, or proper alignment of those muscle fibers which are to be healed back. Okay, so and we have the remodeling phase, that is over a course of period, let us say from 6 months to 12 months of time. Basically in tendon injuries, wherein this blood supply is slightly compromised and thicker tendons. Okay, the scarring is for a longer period of time, and that will take more time, and that will remodel itself to its original in a longer while. Okay, wherein your blood supply to the muscles are pretty much, and they will heal faster. Okay, and they'll have that normal tone of the muscle and the normal musculature at cellular level. It'll be all better in less than 3 months of time, should be. We can also categorize our tissue healing uh, in phases called as acute, subacute, and chronic stages, right? So that's a different category how we see our patients, right? We see that a patient has come to us in acute pain. Okay, we see our patients coming in a subacute phase, and patients who come with us, let us say chronic frozen shoulders, the famous frozen shoulders, adhesive capsulitis, after almost a month and a half, wherein they actually jam their shoulders, and then they come to the physios, right? So that is beyond 21 days, right? So for our understanding, this is also very important, that at what stage of tissue healing the patient is coming to us. Okay, so this is important. Why? Because when patients or clients, they come to you or to us, okay, it is important for their recovery, for their rehab, right? We would want to rehabilitate them back to their normal activities of daily living, or rehabilitate them back to their sport. Okay. Now, when it comes to rehabilitation, there are also stages to it: the early phase, the intermediate phase, and then you have got the advanced stage of recovery. So I've got different stages to it as well. But then in between, you have got a phase called as muscle conditioning. Okay, let us say in the advanced stages, you have got something called as muscle conditioning. So that muscle conditioning is example, you take a case of ACLR, right? That is anterior cruciate ligament repair or reconstruction that has been done. Okay, and then you have a patient with a broken ACL, which is repaired, but in a week's time, you see a drastic change from a normal, healthy quadriceps to a very loose, inflamed, atrophied, flabby quadriceps in just a week's time, right? Why is that? Why does that happen? That are normal. I mean, you have the ACL broken, but quadriceps loses its tonicity. Reason being that, one, yes, it's not loaded. You become very protective. You have got internal bleeding. You have got hematoma inside. You have got all those stuff, and then you have undergone with an ACL reconstruction surgery. You have not done your weight bearing in, let us say, a week's time, right, or less than that. But still, you have got a lot of inflammation, all right, and your muscle starts shrinking very rapidly. It starts atrophying very rapidly. Okay, one thing that connects to that atrophy is pain. When there still has not been a perfect correlation between why a muscle has got when a muscle has got an injury and has got pain, why does it atrophy, or there is muscle inhibition. Okay, so there is no perfect correlation yet, that pain and muscle inhibition, why does that happen? There is no established data yet on that thing. So when we rehabilitate them, okay, when we start with muscle conditioning them, okay, we need to know the right amount of intensity of exercise, the right amount of load that we are giving to that patient, the right amount of range that we'll be going. Okay, examples to that. Okay, and when we develop them, we start gaining back the strength, we start gaining back the range of motion, etc., etc. But still, that atrophy does not go. When we assess them, let us say a month and a half or 2 months later, we still have when we do that girth measurement, the anthropometric measurement, we still lack with 1.5 to 2 inches shorter or lesser than the normal side. Okay, so does that mean that the muscle girth is weakness of strength? I'm trickling down from from an injury perspective to its conditioning, to taking you to pain. All right, okay, and then coming down to its rehab part, and then when the muscle when we are training it, okay, so a decreased muscle mass, does it give you an implication that it has got decreased strength? No. When the muscle mass is less, or you have decreased muscle mass, or if the muscle is atrophied or still not up to optimum what it was before, still it can have good amount of strength or almost absolute normal strength than as compared to the other side. But yes, for girth, we'll have to take some more time, maybe let us say a few months more, and work back to it to develop the same amount of muscle girth, okay, with the comparatively normal side. So there's this something I would like to when we talk about injury, we also need to talk about injury prevention, right? So when we have how can we prevent injuries? Of course, by one thing that goes without doubt is greater strength, right? If you have good strength, if you have got good power, you are definitely preventing injuries. But what more is important than preventing injury? So Gray Cook, he says that uh, the greatest prevention for an injury is not to have a previous injury. If you have a previous injury, you're bound to have it. You're bound to have it again. And you will have it again. For example, if you have an ankle sprain, you worked it out, you gave it good 9 months and rehab, and then you go back to sport, you're bound to have it back again. You have a rotator cuff injury, okay, you work it out, you do it for a year's time, you do it good, you strength well, you train well, and then again, one wrong load, one wrong movement, one wrong position, biomechanics gone. Yes, you are still compromising your rotator cuff. Let it be just a rotator cuff tendonitis, not a tear, but still you are compromising your structures and tissues. So what prevents the injury first is to prevent the previous injury or the first injury itself. Strengthen, of course. Adam Meekins, on the other hand, he says that you can't prevent injuries. Adam Meekins, on the other hand, he says that you just can't prevent injuries. Sport and injuries and training and all of this, injury is a part of it, and you have to get over it. You have to accept it and get over it. If you are loading yourself, okay, just by your home workout, okay, as simple as that, or if you're working out at the gym, if you are training yourself hard, and if you are into sport or activity somewhere or the other, you are causing some sort of minimalistic internal injuries and damage inside. And when you have that, okay, so hence you are developing, but that degree and grade might differ, and the structures which are compromised or which are involved might differ. And you just can't prevent injuries, according to Adam Meekins. What do I have a say to it is that once you have an injury, you have an injury for always. Once an injury is always an injury, okay, for me. So you have to train back, you have to go back to it, you have to work on it, and develop mental resilience. So first is training, and then the second is developing mental resilience. Why mental resilience? You have to get stronger with your mind. You have to get stronger in accepting pain and to overcome it, because there is no specific guarantee that once a structure is damaged inside, might heal, with a scar or without a scar, or might not heal at all. It might always be inflamed inside. You might have bouts of pain coming and going throughout your life. All right. So mental resilience is very important. You just can't stick to your pain. You will have to develop and come out of that zone and work around it. Okay. Will you still be able to go back to your activities? Yes. As far as your structures are intact, yes. You can still go back to your training. It might hurt, but yes, you can go play. Uh, can I go back to gymming? Yes, you can still go. My knees hurt still. I had a torn medial meniscus, conservatively managed. Example. Okay, can I go back to my squats? Yes, you can go. Can I go and do some deadlifts? Yes, you can still go and do it. Are we compromising the structures inside? May or may not be, yes. But do we stop? No. Do we stop with our training, or do we stop with our exercises? No, we do not stop. So mental resilience is very important. When patients come and they are weak in judging that should they continue, should they not continue. For example, I've got rotator cuff, okay, and no matter how I do this delt fly, I do a shoulder fly, it hurts. I just can't do it, and hence I'm not doing it. No, you need to understand, rehab it, work around it. It might hurt, all right, but grow above it and then develop mental resilience to it. So includes train yourself, develop mental resilience. You have to rehab it, become stronger and better than before. Okay, so you might have an injury, okay, you might have a compromised structure inside, but you can train yourself. It might pain, but you might be more stronger than what you were before. You would become more stronger than what you were before, despite that you have a minimalistic or a micro trauma still existing inside. Okay, it might hurt, but you are more stronger, so you do not stop. So accept the new biomechanics. Okay, so you have an injury with the shoulder. Now your scapula is off. There's something called as scapular dyskinesia, famous for physios. Scapula goes off, jetting off the scapula. Okay, the winging of scapula. The serratus anterior goes, is let us say is not functioning properly, is not activated, is not recruited. You know, those words that we hear. But do we stop to train yourself? Do we stop exercising? No, we continue. And what do we do in that circumstances? We accept the new biomechanics, the altered biomechanics with that same thing. Okay, so that goes with any of the joints that you take, whether it be shoulder or your elbow or your the knee joint. Okay, same thing goes with your squat training. When it comes to squats, everybody has got a different style of squat, a different depth of their squat. Okay, you have got a pretty normal freestyle squat wherein your feet are or slightly 10 degrees parallel, or you have a parallel feet, and then you go squat. So that's a very normal squat. Certain people have got a very wide angle, a very large base of support, and then they would want to squat like that. Okay, so why is that? Okay. Because there is high chances that you have got femoral anteroversion or retroversion inside. Okay, be by gross subjective assessment or just by observation, it's slightly difficult to say, right? But if you have it, yes, the body has adapted. Our body has adapted its new biomechanics. Okay, so so we have to be very strong and mentally resilient to all of this. Now coming back to our practical session, wherein we will be demonstrating that how do we do certain basic warm-ups before the exercise, certain different types of stretches that what you are supposed to do after your exercise. Okay, so let's. Okay, something that before your exercises, okay, what I want that your neck should be free. Your neck has to be free, and you should not have a very strained neck or your trapezius are tight, etc., etc. You have a slight niggle in the neck, etc. So let's do some normal physiological range of motion or movements, normal neck movements, okay, and get your neck free. Okay, do those forward flexion, extension, rotations, and side. You can have your arms at the side. Okay, just go up and down. When you're done with your neck movements, okay, we want our shoulders to go round. So circumduction of shoulder movement, rotation of the shoulder joint. Also go inwards. Open up your chest. We'll do some hip mobility in standing. Okay, that would be outward rotations of the hip. Alternate up with you. Alternate. So hip rotations, hip mobility is very important for any sort of sporting activity right before the sport, or you don't want your lower back to get hurt, you don't want your hip joint to get impinged some structures inside. I want, okay, I want you to go down and try and touch. Hello? Yes. So we would want to open up lumbar spine, okay, you can come back up. Go down and rock yourself a bit more. Come up. Okay. I want you to go down, go deeper, behind, and come forward. Go deeper, behind, and come forward. 1, 2, 1, 2, 1, 2. Okay. That is it. Thank you. Give me a mark. There are certain drills that we want as a warm-up mobility drill, okay, to be done on the mat before the exercise. Okay. Okay, yeah, you can come in.
Yeah.
Okay, we have got Dr. Priyanka with us. Okay, he was behind the screen handling. All right, Priyanka, please come. Okay, something on the mat, that I would want my patients or athletes before an extensive exercise or before the sport to have this warm up on lumbar ranges. Okay, you can have that face up. Have your arms open wide, okay, and you can take your right leg straight up and rotate and try and touch the ground on this side. Okay. Then you can go straight back up, okay, and then come back. Starting position and alternate with the other leg. Okay. So this is scorpion. Can you just change the side view, please? Good. We can also do a reverse scorpion. All right. Same thing. We can do it face down. Right. Uh, that's it. Now. Good. Extend your leg. One more. Extend your leg straight up and touch and back and down. The other leg. Extend your leg up. Eight. Down and down. Thank you very much. One more. One more. Okay. So this was the scorpion exercise, and then the face down was the reverse scorpion. We have got also a very this was also called the universal stretch. Okay, before we start, demonstrate a universal stretch. We do it sideways. Like this. You'll have your right leg forward. Have your right leg forward, and your left hand goes up towards the ceiling, and your face turns up. Okay, so you get a good stretch of the other side, all right, and switch. And then left leg goes up, okay, and right hand comes up towards the ceiling, okay, so you stretch, gives a good stretch on the right side, it flexors and hamstrings. Okay, switch, you do that one more time. Stay there for a count of 1, 2, 3, switch. That is it. That is it. Okay. Thank you, Priyanka. Thank you. So you have got these basic stretches that you can do before your exercises. Now coming back to what we started as simple as T-row. When you do or choose to do exercises with your TheraBand for your shoulder, for example, when you have a compromised shoulder, okay, and when you're training for beginners, something very simple, very simple. I would not want my patients to lift or do a shoulder front raise with a TheraBand or with a dumbbell with a pronated arm. I would avoid all movements, okay, with a pronated arm. When you have a rotator cuff injury, or when you have a supraspinatus involved, or when you have, let us say, even a bicyclitis kind of thing, okay, so I will avoid a pronated arm front raise in the beginning. I'm not saying no for all, but I would prefer to go with thumbs up. Okay, because when you do a thumbs up, okay, you are externally rotating your GT, right? Your greater tubercle, okay, and then you're clearing it out of the acromion, correct? So in that way, when you do a thumbs up, front raise is more easy, doable, and you do not compromise or impinge structures inside the shoulder joint. So start training with a thumbs up position. You can start with 90 degrees of flexion, go to 100, 140. It's a very good range. Okay. Same thing when you go sideways with abduction. Okay, so start with a thumbs up position. Now, start thinking critically that if you are treating your patient, okay, with a pronated arm and you are flexing it that way, okay, you are doing forward flexion, you are compromising or impinging it more inside. When you're doing an abduction this way and you're telling your patient to actually go up to 160, 170, 180 degrees of abduction, you are causing more impingement, okay, inside the shoulder joints. So you're causing structures to actually cut more further beneath the acromion. Okay, so this is using the therapy. Okay, so heroes, this is more a deltoid dominant. Okay, and when you're doing it with palms up, is more biceps dominant. So you will have to choose it wisely. If I want to train shoulders, I would do it with a palm down. If I'm focusing more on my back, I would do it more with palms up. Certain things. I don't know if you can actually move time. This, can you see me here? Is it too far? Too far? Can you see me?
Yeah.
Okay. A simple exercise that is very commonly recruited by physios for doing low rows. Okay. So when you're doing a low row, so you pull, you pick up the slack and you pull to the side of your body. Okay. This becomes your starting position. Right? This becomes your starting position. And then from here, from this position, you pull up. 1, 2. So this is how you are going to focus more on your lats. Right. But what I have experienced that how people get trained and how patients to do it is for this simple exercise, they have the starting position right here, they pull back 1 and so you move forward. 2, 3, 4. So they are using the engagement of their muscle, the recruitment of their muscle. So they need to keep it engaged and then do. Same thing goes with a high row or a chest row. So you need to engage your back first. You need to have a retracted back, a flat, a better posture, and then you go. And not in the other sense, and not this way that you are actually pulling it from this part and your back is hunched, but you're very hunched, and then you want to pull it. No, you don't want that. Okay, so very simple things that can be avoided, can be corrected. A very common mistake that now, for example, training your shoulders. Someone for beginners. Okay, when you want to train. Okay, so you would want somebody, okay, to do a shoulder press. You want somebody to do a shoulder press. Someone who knows how to do a shoulder press, who has the strength, who has already done a shoulder press, fine. You go and give them a shoulder press directly. Okay, they might be able to do it. For some who has got, again, a compromised shoulder, how you train them? I would want their back to be seated, Okay, the back to be supported. I want them to be seated at an angle of, let us say, 80 degrees. Okay, I want an 80-degree inclination from the bench. Okay, and then I want them to recline back. Okay, starting position, and then do a shoulder press. So now this comes right above the forehead. That's it. So someone who is starting to do exercises as beginners can do this exercise for their shoulder. Same thing, can you stand? So now when it comes to shoulder flies, okay, so would you do a shoulder fly? Okay. So a shoulder fly, I would want, as the arms are pronated, I do not want my patients to actually have a shoulder fly this high, okay, which crosses beyond 90 degrees here. Because repeated motion will cause an injury, an overuse injury, we call it, or an impingement injury, but some sort of the other injury you will experience. So I always want, okay, my patient or when I train less than 90 degrees for the shoulders. So here your biomechanics matters at what range you are supposed to do your shoulder exercise. Same thing. Now the shoulder is healed, or for example, you can actually go for a front row. You can go for a front raise. The pronated arm. Again, I'm not exceeding 90 degrees. Right? Same thing. When you want to do anterior, when you want to do a chest press, or when you want to start working on your pectoral muscles or your anterior capsules, all right, so you do chest press. And yeah, straight up. I don't know if this is possible. I don't know, they can't see it. Yeah, it should be fine. Yeah, that's fine. Okay. Now, someone again who knows how to do a chest press, I would directly take them into the starting position and train them this way. Okay. But now, if I know that they have an injury with their pec major or their pec minor that is sore, or you have got some sort of, a trigger point or something, a bad injury with the anticapsule, they have any sort of what do you say, anterior shoulder instability. The capsule is weak, the anterior capsule is weak, etc. All of that complex. If they have issues with that, I would want to come up. Want to incline the seat to 45 and this is better, this is safer, this is a beginner, and that one is a bit more advanced. So the choice of your position while doing your exercise. Are you trained well to do actually that, or you can start with something smaller and better? Okay. 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 As simple as can you see his feet? Priyanka, can you see his feet on the screen? Yeah. Come forward, starting. Okay. So Dr. Redis will now perform a squat. Basic squat. Okay. A couple of more times. Okay, so that is the front view, okay, for a squat. In this, turn towards, yeah, turn towards me, slightly more behind, then do a squat. Okay, that is fine. If I have to correct him, if I want a more quad dominant squat, all right, so I would want my patient to have more parallel feet more parallel to and slightly inwards, okay, from the normal 10-degree toe out, all right, to be more parallel, the feet more parallel, and then take a good pelvis width stance, okay. So I'll not be standing too narrow for a squat. I'll not be doing a very narrow squat. I'll not be doing it. I will not ask my patient to actually have a very wide base of support and then do a squat. I would want to correct them to have a pelvis width base, okay, and to have parallel feet, and then do a squat. In this position, I am being more quad dominant, right? But if I want to train somebody who is willing to lift weights or wants to do a barbell squat, okay, wants to have a barbell, right? So I would want them to have a more wider base of support, okay, and their feet or their angle of toe out to be more than, let us say, 11 degrees, 10, 11 degrees, or slightly a bit more wider, because a wider or the more the angle of toe out, you can actually have a deeper, you can get more depth. Okay. How do I see or train squat with patients who have got issues with valgus or vas? Commonly, what we see is patients who have got a wider base of support than their pelvis, but are knocking at the knees, or have got their feet, who have got their knees knocking each other, or have got a knee valgus. Okay, so in that case, again, I would want to correct them to have a parallel, okay, keeping the feet parallel, having a band around a thread loop around their knee, okay, and then actually ask them to exert the force laterally outwards, engage their glute medius in specific, have the force coming outwards, and then in a way, am I correcting the valgus? Maybe not. I'm just correcting their squat, making them strong, nothing else. Okay. So these are certain simple, it's a very vast and a very varied topic, okay, which is slightly, difficult to cover in a very short time. Okay. So as far as biomechanics was concerned, or as far as this correction was concerned, there's certain topics that what I could cover up till now. So I presented in front of you. I am now willing to take any questions and doubts from you all, so I can definitely try and answer them. Okay, I've got people have asked a few questions. That is, what is the role of ergonomic for prevention of injury? Okay, the sport ergonomic would be uh, developing the right skill. Okay, training the right muscle. Uh, for example, let us say a tennis player. Okay, if we have a tennis player and wants to train himself for that sport, okay, and wants to prevent from injuries in that sport, and he works out only on his upper body, works only on his shoulder, okay, works only on his let us say triceps and his lats, etc., okay, and his agility of his upper body, and is not focusing on his lower body or his lower extremities, is absolutely wrong. Okay, so, and when it comes to football, I would train, or I would train the athlete to have uh, wear the gear, wear the right shoes, wear the safety guard, and have those right braces on, and with that amount of weight which is added to the player, and then train with it. So hence you can prevent injuries while how you train, and then you can you know uh, uh, prevent injury. Which protocol according to you shall we follow initial exercises? Okay, I do not go with the term protocol. I absolutely don't follow much of protocol, because every individual, every patient, every athlete is individual. Yes, you have certain amount of guidelines and protocols that you can follow, but exercises, I believe, are very individual. So you'll have to see yourself that what suits you best. I am not saying that, when it comes to training or rehab, start with therabands, or start with, a very low dumbbell, or start doing dumbbells. Don't go to heavier weights, etc. When you I believe start with body weight exercises. That would be actually more beneficial. You can start with free squats or push-ups, or doing more of core exercises and things like that. And yes, of course, as a physio, I would be slightly biased and inclined towards doing your bands and those works, because yes, it does help it, because there is a difference between using a TheraBand and a dumbbell. Okay, because TheraBand gives you incremental weight, right? So a TheraBand gives you an incremental weight. When you start, you have a tension of 5 kgs. Once you reach the end of the range, where you are having a tension of, let us say, 10 to 15 kgs. So you have got incremental weight. So I believe that this is slightly more beneficial, because when you feel that the weight is more, you come down, and then the weight also comes. So you have decremental eccentric control over your band or the weight. Whereas when you have a 4 kg dumbbell, and then you're doing your exercises with that, when you see a point wherein you are not able to take it, you might have to drop it, okay, and you might get slightly more damage, if you're not that prepared for it. Hence, you need to have your proper warm up and post exercises proper cool down. In post operative rehab, what shall we initiate with? Is it strengthening or stretching or else? Okay, I would say this is, I'll just have that. Very good question. In post-operative rehab, what shall we initiate with? Is it strengthening or stretching or anything else? Depending on what the structure is involved. Let us say you have got a TKR done, or a knee surgery done, and has been under a plaster cast. Okay, ankle has been free and was not under the cast, was not immobilized, etc. Ankle is supposed to be free. So, and if that ankle is getting tight, what would you do? You would stretch your tendon, at least you will do a TA stretch. But at the knee joint, would you want to stretch those structures or soft tissues post surgery? No, you would want to strengthen it. So start with isometric exercises. Any surgery, post-surgery, whether it be a TKR, a THR, or a shoulder arthroplasty, a shoulder replacement, or even plates and nailing done, etc. Any sort of post-operative surgeries, first thing, focus. Then I would say range as the priority. Focus on range. Come back with range. Range and isometric exercises will go hand in hand. And post-operative rehab, you have got a race with two things. You're having a race with two things. Post-operative rehab, you are having a race with stiffness and range. Once you're out of cast, once you're out of phase of immobilizations, once the orthopedic surgeons have given you a green signal to start with rehab, once you have started with rehab, so you will have a race. So stiffness will start setting in faster than your range. So you'll have to focus a lot on your passive movements, as simple as that. Your passive movements, your active assisted range of motion exercises, your good isometric control, your good isometric strengthening exercises. Very important. Are we done? Got one more question coming in.
Anyone like to ask any questions?
Yeah, you can actually directly come and share your screen and ask the question.
Seems like no doubts. So good.
I have no idea if this was absolutely absorbable. Or 1RM, which protocol will you suggest? I would say you can actually have a formula for it, and then you can choose to select that formula and go and decide of how much of 1RM would you want to go. Let us say if you're having your reps, let us say you're lifting 10 kgs, for example, with a 7 to 8 repetitions, your 1RM might be at around 15 kgs. I would not suggest a specific protocol for 1RM. I would not go with the 1RM science of weight training. I would go progressively. Something else? Do we have any other question? That is it.
I would like to ask one thing about Osgood in athletes.
Osgood-Schlatter?
Yeah.
Osgood-Schlatter disease is let us say a teenage developed condition in the teenagehood, and you would have to train them with regards to their strength, their bone density, and their muscle length. You will also have to be focused on their knee range of motion, and their pretty much multi-dimensional. But yes, again, avoiding all sorts of jump activity, all sorts of plyometric activity for a while, and having a good length of the muscle, very important, and a good range of motion, very important. Avoiding joint stiffness, and then yes, of course, so avoid sorts of plyometric exercises when you are diagnosed with Osgood-Schlatter disease. But yes, you can of course continue to play your sport. You have got many adjunct exercises that you can still do. Osgood-Schlatter disease in certain times from their childhood, from teenagehood, is carried up to their adulthood, as far as when you are up to 25 years of age, when you have achieved your bone maturity and still you have got some reminiscence of pain in your knees, for athletes. Yes, only for athletes. and they have got a greater stress-induced tibial condyle, greater bone density, because they're highly impacted. They have those changes. You have got greater, tibial tuberosities there. Pretty pokey. Next. Okay. Okay. Okay, Tahir, Vishnu, I can see 2 medical members. Okay, thank you so much. Thank you so much. Thank you.
Thank you so much, Dr. Yasir and his team. It was a really informative, interactive, and like demonstrative session, and I really loved it. And it is something that I can definitely relate to. So thank you so much.
I could not give examples of lower back pain and knee pain or knee rehab. It would have been really, too long for this short session. So I was slightly, pertaining to shoulder, which is easy to understand, right? From the BPT or MBBS or any medical background, where shoulder is somebody's is everybody's favorite. I mean. Okay, thank you. Thank you so much, Tahir.
Thank you so much for being here. I've sent the post event form on the chat. Everyone, please fill the post event form and give your feedbacks. It would really help us in future sessions.